Welcome back. This is episode 44 of the MedEdit podcast, your go-to resource for evidence-based medical education.
And the only podcast where two board-certified physicians break down health myths, explore science-based strategies, and bring you the answers you need.
Today, we have a return guest, our favorite pulmonary critical care specialist, Dr. Ximena Solis. She's going to be breaking down some facts about asthma, and then stick around, we review lung nodules.
We've got a lot to cover, so let's go ahead and get started.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast. We are so lucky to have Dr. Solis back to talk today. If you have not listened to her previous appearances on the show, go check them out after this one. But we're going to start with the basics, Ximena. What is asthma?
Yeah, so asthma is kind of one of those interesting things because there's not a set blood test or physical exam finding or any other test we really do. So it's technically a form of chronic airway inflammation, and it's usually characterized by wheezing, shortness of breath, chest tightness. And kind of what's classic about this is that it's waxing and waning. So symptoms can be intermittent. And usually people endorse a type of trigger, but at the end of the day, it's basically a form of airway hyperresponsiveness.
So especially with kids, because I think that's what happens a lot is when I have adults establish care with me, they'll be like, well, I had childhood asthma. And I feel like that's a really common thing. It's just childhood asthma and they have nothing now. So when they're in, as a child, is it really common to be diagnosed with asthma? Because it sure seems like it and then grows out of it as an adult.
Yeah, that's a common thing. I feel like a lot of kids now with the surgence of allergies and things like that get diagnosed. And then there comes a period of maybe in adolescence or early adulthood where symptoms go away. And then you can even get adult onset asthma. And not a lot of people realize that sometimes you don't grow out of these things and you can have symptoms lifelong.
I have a patient actually this week that we've been working on that. We think she's going with working with the allergist and immunologist right now because she had this crazy cough she developed and she was so sensitive to anything with like smells, perfumes, anything around it. It was so bad. She could not breathe. Like the poor woman could not get words out. And so we ended up starting her on several of the controller inhalers and doing all these things, did a huge workup. And so now she's with allergy and immunology. She can finally have a conversation. But they showed a restrictive airflow pattern when they were doing some of the testing. And so it's been very interesting that at 62 years old, this all of a sudden came on. She's not a smoker. She hasn't been exposed to any crazy weird chemicals or some environmental factor. And as it turns out, they keep saying it's allergy, I guess, associated as well, which I thought at 60 something, you're kind of over developing something like an asthma.
Yeah, we saw a resurgence too with COVID. A lot of people were getting reactive airway disease after COVID. So now I feel like everybody's more aware of it because we're seeing it more than we did ever before.
And I think just because, I know how you're describing it, but for some people, I think it's kind of hard to envision. So say you were going to like cut somebody open and cut their lungs open and they have asthma. What is going on in their airways compared to like normal lungs when these things happen?
Yeah, so basically asthma usually causes a surgence of inflammatory cells, types of white blood cells that kind of come to the surface of the epithelium. They release chemicals, release histamine and things like that. And basically the airway is clamping down. So I always tell my patients, imagine like you're squeezing a garden hose. It's going to be much harder for water to travel back and forth. The same thing is practically happening in your lungs. They're basically closed off and you can't travel air back and forth. And so usually this problem goes away. But if you have chronic inflammation, those cells will actually cause damage to that muscle and cause remodeling over time. And so sometimes your breathing does not get better. You kind of develop a constant state of being in an asthma attack. And you can actually get chronic obstructive pulmonary disease or COPD from uncontrolled asthma. And so it's a big deal to be able to get these symptoms under control.
Yeah, absolutely. And I know you kind of mentioned, or you guys were talking about some atypical type asthma. And I feel like a lot of people, I don't know if it's because of media or TV, think that they know what asthma looks like, like these people like just gasping for air and they use this inhaler and then they're fine. And that's what all asthma looks like. But what are some of the typical symptoms really seen with asthma? And then some of the maybe more common atypical symptoms that you see?
So the typical symptoms, kind of like you were describing, chest tightness is kind of the number one. Wheezing, of course, is classic. Symptoms that are worse at night can also be kind of typical for asthma, usually a trigger, like I mentioned before. But some people don't realize that even just a dry cough can be asthma. And so that usually is what, patient gets referred to all these specialists for. They get referred for a cough, and at the end of the day we find out it's asthma.
Yeah, we've done our GERD workup too, usually by that
point. Good. Yeah.
So you mentioned some of the atypical symptoms that can correlate, and then there's different types of these asthma that we see, typical, atypical. What are the other types we haven't maybe covered?
So kind of the one that everybody thinks about is allergic asthma. That one's mediated by eosinophils, IgE levels. You do allergy testing on these patients. They have multiple things. We usually, in that case, refer to allergy and immunology, do workup and see what treatment needs to be done. Because if you treat the allergies, the asthma gets better. There are some people that have what's called non-allergic or intrinsic asthma, and that one has a different type of cells, more neutrophil predominant, and it has different IL molecules and cytokines that are released that cause that airway hyperresponsiveness. And that one is more difficult to treat because they don't usually respond to treatment like the regular allergic asthma patients do. And so those are the patients that you put them on the kitchen sink of medications and they don't feel better. And so there are some newer medications that kind of start the pathway, start killing the inflammation at a higher level on the pathway. And that's the one where we've tried everything, and we try this biologic medication to try to knock down inflammation, but definitely harder to treat than the regular allergic asthma. And then, of course, you can get occupational asthma. You have something in your workplace, fumes, chemicals, something that causes you to trigger a wheeze, be short of breath. Usually you get better if you're away from work. And there's also exercise-induced asthma, and that one is not mediated by allergies. It's basically just the act of exercising and exerting yourself causing airway hyperresponsiveness. And then we're also learning more about obesity as well as being a type of asthma on its own.
Yeah. And I've even seen reflux be a trigger for some people,
Yes.
Their asthma as well. The cough thing, it's hard to tell. Is it the reflux causing the cough? Is it the asthma causing the cough, or the reflux causing the asthma? Which,
yes,
nobody really can
or
answer
even like
easily.
postnasal drip too. Postnasal drip, not a lot of people realize if you have something that's constantly dripping in the back of your throat, it's going to trigger your airways over time.
Yeah. So. And like we throw around the word trigger a lot, when we talk about asthma, and I think some people understand what that means, but what are some of the kind of common triggers? I know you mentioned some of them, but even maybe environmental or such that you see.
So a lot of people say, pet dander, mold, ragweed, things like that, common allergens that may be in your area, but it can be also temperature, humidity, different smells, perfumes, things like that. Air freshener is also one I hear quite often. And then also exercise, like I mentioned, and acid reflux, postnasal drip. It's just anything that can trigger that response. It can happen. You name it, somebody's reacted to it pretty much.
So are there risk factors for someone to develop asthma?
Yeah, so a lot of times we see it in patients who sometimes with prematurity. If your mother has asthma, you have a higher chance of developing asthma as well. Certain infections in childhood, like influenza, RSV, things like that, human metapneumovirus, can kind of set you up for asthma in the future. And then also if there's any kind of congenital abnormalities as well. But the more interesting thing we see is if someone has smoked around you when you were growing up. So secondhand exposure.
So when you mentioned the things about having maybe like a child that has had recurrent, viral infections, does it matter how many they have? For example, so my son had RSV, I think at least 7 times before the
Mm.
age of like 3.
Wow.
And so he wasn't premature or anything like that. So you sit there and you're like,
Mhm.
okay, is he more at risk for developing asthma down the road because he's had those, those infections?
Mm-hmm. It's not so much the number of times, kind of, it's more on the severity. And so, we saw it too with COVID. Some people would get mild COVID. Maybe they would have some asthma type symptoms or reactive airway disease for 6 months or so, and then it would go away. Patients who are in the hospital, super sick, in the ICU, they might have lifelong symptoms. So I think it's more based on severity.
That's really important. Okay, so let's say someone comes to see me with some of the symptoms that you've mentioned. I'm in their primary care clinic. We're sitting there. We're like, okay, I think this is probably asthma. We maybe even, give them an inhaler before they leave, just so that we don't end up with some, scary situation. We send them over to you. How are you going to truly diagnose them with asthma, or at least rule it out? Let's say it's just not a clear-cut picture either.
So I like to get a good history and kind of identify those classic symptoms, if they have any triggers or anything like that. I ask them about previous infections, if this came on after that, anything they can identify. I always get a spirometry at least on patients when they get referred, and that lets me know if there's any airflow obstruction. And then we also test for bronchodilator response. So one of the classic hallmark, quote unquote, symptoms of asthma is that it's a reversible disease and it responds to bronchodilators. And so we always test bronchodilator response as well. There is a more specialized test called the methylcholine challenge test. And that one, basically, it's a little cruel, but we give you a medication that will trigger your airways, and we take measurements. And so we expose the patient to increasing doses of this medication, and it's an inhaled medication. And then we basically make them do the spirometry over and over again. And if you have a certain response above a 20% threshold, we consider it a positive test. And so that one is one of the ones that it's very good. It's not 100%, of course, but it's, I'd say, in the upper 90s to be able to rule out or rule in asthma. And then we can also do blood work. We look at signs of high eosinophils, or a type of white blood cell in the blood. We look at IgE levels, looking for those allergic triggers. And we test for kind of also mimics of asthma. So even like a vasculitis or an autoimmune condition can present itself with airway symptoms. And so kind of between all that, we usually are able to come up with a diagnosis, or at least lower on the totem pole if those tests are negative. And there is a specialized test that, we all learned about in fellowship, and it's kind of more in academic places. It's called a pheno test, and it's kind of measurement of gases, and if it's above a certain threshold, it's positive for asthma. But we don't really do those kind of in regular practice, I would say, or at least I haven't.
Yeah. It's kind of like how I knew I didn't want to do cardiology when we went out to physiology. I knew I didn't want to do what you do when they put spirometers on tests, or spirometry results. And I was like, nope.
Yeah.
No, thank you.
They were so hard. And now it's like, it takes me 2 seconds to look at it.
They were so hard.
Yeah.
I know that the type of treatment you initially suggest might depend on the severity of how someone's asthma is categorized. So can you review some of those categories based on the result of the testing that you just mentioned?
Sure. So once we kind of have tests that support that diagnosis, along with the physical exam and history to suggest that, we basically drill down, and sometimes patients get annoyed. We ask them, how many times a week are you having symptoms? And is this happening? Are you reaching for your inhaler if you have one once a month? Is this happening every day? How many times at night are you waking up? And so those are all very important, so we can categorize their asthma. So we have mild intermittent, moderate intermittent, or persistent, and then severe and refractory, basically. And so based off the number of times the patient has symptoms, that lets us know as a clinician what medications to suggest. And they actually recently changed the guidelines for asthma treatment. Back in the olden days, we used to just give people albuterol or a short-acting bronchodilator, see how many times they used it, and kind of go from there. Now the recommendation is actually a combination of a long-acting bronchodilator and an inhaled corticosteroid, and using that as needed. So that's kind of our first step. And it's usually at a lower moderate dose. If we find the patient is using that consistently, so I'd say probably more than 4 or 5 times a week, that's when we kind of move on to using these medications on a regular basis. So using the inhaler twice a day, every day, no matter what. And based off of that response, if they're still symptomatic, we increase the dose of that medication. The next step is, of course, moving on to what's called the LAMA, or long-acting muscarinic antagonist. And that's just basically another inhaler that helps lessen the cough response, open up the lungs in a different way. And then, of course, if any allergies come along, we treat those also with leukotriene receptor antagonists, or montelukast. A lot of people are on that singular. And so we basically try to max out the patient with as much of these non-invasive things as we can. When the patient becomes refractory to all of these medications and they have multiple exacerbations, you end up having to put them on chronic steroids, and we all know how bad steroids can be long term. When you get to that point, you need to consider advanced therapies called biologics. And so, based off of their blood work and any other, clinical features, there are certain medications that target the inflammatory cascade for asthma at different points. I kind of alluded to that earlier. There's newer medications with the neutrophilic type that kind of cut that pathway off from the start. But we usually kind of try to target either eosinophils or interleukins to try to lower those levels of those things in the patient's blood, so they're not constantly being triggered. Those cells aren't reaching the epithelium of the respiratory tract and causing that reaction. So that's multiple ways to kind of approach it, but that's kind of our next step. That's usually when they start seeing an allergist or a pulmonologist, is when we're getting to that point.
I think that's actually so cool. I think we all here we're all in similar era of training, where when we were in med school, there was a certain way we treated certain disease processes, and then in residency, and then we've been out long enough as attendings for this many years to be like, hey, that's also changed. And in my mind, like for primary care, things that have had huge developments were migraines. I now no longer hate treating migraines because we have advanced treatments that are way better than we used to. Diabetes is way better than when we were in training, like phenomenally better. And then also asthma. And so I love seeing some of my patients, especially my teenage or young kids who grew up going to the hospital, the ER all the time, admitted. They were in the ICU quite often. They'd been on everything. It was just really kind of scary. And then now they're on some of these biologics. And I mean, I think of my one guy, and I'm just like, it's shocking how well controlled he is. Even just at, now 20 years old. It was only a couple of years ago that he was still doing horribly. And then this also biologics help with some of the other things that are related to asthma, like his eczema as well, and his other allergy symptoms. He's getting so much benefit. So it's really cool what you're doing in using some of these medications that the biologics have been around a little while now, but I feel like they just keep getting used for different purposes. Is that right?
Yeah. Yeah, they study more about these things every day. So like Dupixent that we use for asthma and for nasal polyps, it now has an indication for COPD, or chronic obstructive pulmonary disease. And so there's different, in Nucala, the same thing. And so the longer we go with these biologics, there's going to be newer ones, but we're learning how to apply the ones that we already have as well, which is very interesting too.
Yeah, I love that. So on that same note, then, we've seen that there's apparently possibly some new data around GLP-1s and asthma control beyond, just using weight loss. Can you tell us about that a little bit?
Yeah, so it's real interesting. It goes along with the neutrophilic pathway. I mentioned that earlier, and that one we see also with obesity. And these GLP-1s, we're learning more that they are knocking down inflammation in the entire body, not just for weight loss. And so one of the methods that GLP-1 works is by lowering IL-6, which is one of those immune mediators that can trigger patients in the neutrophilic pathway. So we're studying more about it. There's nothing kind of official out on, the American Thoracic Society journals or anything like that. But there is there's a sign that it's working. And then also too, anytime a patient has obesity, they are limiting their pulmonary function, their capacity. And then also, if you can think about it mechanically, they're crushing their airways just because of their body habitus. And so weight loss on its own will also help asthma.
Yeah, very cool.
Mm-hmm.
Yeah, one of the other really cool treatments that I kind of was reading about reviewing, asthma for this was about bronchial thermoplasty.
Oh, yeah.
Yeah, which sounded very intriguing. And I really just kind of want to ask you what it is.
What is
and
I don't
when do you
what
use
is that?
it?
Yeah.
Well, I mean, before the era of biologics, that was our next go-to. So if we basically maxed somebody out on inhalers, had them on steroids, and they still weren't better, that was the go-to. Now it's the last resort. And so basically, yeah, it's radiofrequency ablation. And so it's done by bronchoscopy. The patient's put to sleep. There's a special catheter that is inserted into the airways, and it basically ablates that tissue. And so that tissue that has become inflamed, hypertrophied, we're basically destroying it and trying to get to the quote unquote normal tissue that's underneath. And so it's very good. We have to do it sometimes, but it's not the norm anymore. It's kind of one of those, I can think on one hand how many patients I've taken care of who've had to resort to that. But it's there. It is useful in the right patient. There are some horrible things that can happen. Patients can get increased hyperresponsiveness of the airway temporarily after that procedure. You of course have to undergo general anesthesia, and it's not a one and done. Sometimes it requires multiple treatments. And so those are some things that people just aren't aware about that can happen with us.
So why is it important to control your asthma symptoms if you have them, and what can happen long term if you're just ignoring it?
So long term, basically you develop COPD or chronic obstructive pulmonary disease. It's doesn't matter if you smoked, or you can still get COPD from other reasons. And it all goes back to the inflammation, and it all goes back to airway remodeling. And so if you let the inflammation run crazy, that is just going to remodel your airways over time. They're going to be thicker. The lumen of the airway is going to be smaller, and you're going to be living in a constant state of being short of breath. And so you can get to the point where this is no longer reversible, and then you've basically knocked down your lung function at 45. So it's no longer asthma, it's more of a COPD, and then it's basically progressive from then on out.
Yeah. And I think we've all unfortunately seen some of those cases. Less now, of course, like you said, but we've seen them. Well, I think we just did a really amazing job at reviewing all there is to know about asthma. So like we've talked about, talk to your doctor if you have concerns before you just self-diagnose yourself or you buy something online, because it is really important to get these symptoms under control for the long term. So we're going to switch gears just a little bit. I kind of just wanted to briefly review lung nodules, or quote spots, as it was referred to in some literature for the layperson. With over 200,000 new cases of lung cancer a year, this is an important topic. And I know, Dr. Solis, you recently helped pilot a new lung nodule clinic at Covenant Medical Group. So tell me, why is this important to you?
So the earlier with lung cancer, the earlier you get someone diagnosed, the better the stage and the better the outcomes. Too many times I have gotten patients who maybe had a lung nodule a year or two before, it wasn't followed up on, they were lost to follow-up, something like that. And then they come back and they have stage 4 cancer. And with lung cancer, we have a lot of advances, but it is still very difficult to get somebody to a point where they have good quality of life or to even survive it. And so I'm really passionate about this, because the earlier we get somebody diagnosed, and let's say the treatment is as simple as a surgery and their cancer is quote unquote cured, that would be the best case scenario, instead of having to go through chemo, radiation, and have the cancer come back and spread to other areas. And so the earlier we can get to it, the better.
So I know that this is something I deal with all the time whenever we find an incidental finding or something like that on we were maybe scanning their stomach, we're looking somewhere else, abdomen, pelvis, on a CT scan. They're like, oh, there's a lung nodule at the bottom of that. Go look back later. And then my patients first concern, I actually had this conversation this morning with a patient, was, is it cancer? So when you see these nodules, is it, are you most of them cancerous, non-cancerous? Are most of them found incidentally on imaging performed for another reason like this?
So I would say most of them are incidental and kind of nationwide. That's the case. Usually we're checking for something else and we find it. I would say most of them are non-malignant. Of course, my patient population is going to be a little different, but nationwide, most of them are not malignant. So we have different guidelines that let us know how concerned we should be about nodules, depending on how big they are, where they are, what they look like on imaging. And, our guidelines are called Fleischner guidelines, and they tell us either, repeat a CT scan 3 months, 6 months, 12 months, or never, if it's a low risk nodule. And then sometimes it recommends that we get a special scan called a PET scan to see if there's any signs of malignancy. And then after all of that, we would be able to see if we need a biopsy. And so you kind of have to go through all that pathway before we just automatically go in and take a biopsy of someone's lung.
Right. Yeah. And I think, people listening to this will probably say, well, I'm sure I would have had symptoms if I had a lung nodule. So do you typically see symptoms with people with lung nodules? Because I don't.
No, that's a common misconception. Your lung parenchyma actually does not have any pain receptors or sensation receptors. And so you really don't feel anything. You'd be surprised how big something can grow in your chest before you start to feel symptoms. And so, most people are completely asymptomatic, and we are talking about millimeter measurements on people's lungs. That is how small we're able to pick up with CT. And so this is something I always tell the patients, 8 millimeters is the size of a pea. And so sometimes people get referred to me for a 4 millimeter nodule. I'm like, your nodule is literally half the size of a pea. You can't feel it. There's no way. But yeah.
Interesting. And I feel like this next topic is something that has actually really changed and progressed during all of our training is screening. Really. I mean, I feel like when I was in med school and stuff, like this was way different than what it is now. So who are you recommending screening potentially for, technically cancer, but, precancerous nodules as well?
Yes. So there is official recommendations for lung cancer screening. We usually start to look at, and it depends on insurance, which guidelines you kind of look at, but usually above age 55. And it's patients that have smoked for over 20 pack years. And they have either been smoking or quit within the past 15 years. And they're able to enroll in this program that's called a low dose CT program. So it's a lower dose of radiation than a traditional CT scan. And so we basically put them in the program, make sure they qualify. If we find something, we will go along our algorithm of repeating CTs or PET scans or biopsy. But for most people, it's just a CAT scan that's once a year just to check up on things. And so it's a pretty easy test. Patients tell me it's like 5 minutes to get a low dose CT, and we get a lot of information. It provides us with reassurance and provides the patient with reassurance. And if we find something, we're getting ahead of it. We're not reacting to something.
No, I love it. I refer for that all the time, and it's become easier and easier and easier to get it covered by insurance as well. Right. Patients are actually happy because we've caught things and monitored them much more closely. A lot of those programs even having smoking cessation programs associated with it to kind of help you quit smoking if you're in that category as well. So I'm so thankful that the science has evolved to help support that. So let's just say we have my patient, like I was talking to this morning, and, we found an incidental lung nodule and it does need further workup. And I send them to you as the pulmonologist. What can the patient expect for that further workup at that point?
So we usually try to do risk stratification. And so we will ask them, are you a smoker? Have you had this nodule before? Anybody in your family have a history of lung cancer? Do you have any high risk occupational exposures? Are you immunocompromised? History of cancer, things like that. And so after we get that history, we calculate their malignancy score. And so we determine if this is a low, intermediate, or high risk nodule just based off of the CT scan we have. And After that, we look at its size and kind of determine, do we need to proceed with further workup, like another CT scan in 3 months, 6 months, or do we need to get a PET scan or a biopsy? So the initial visit is usually just a discussion. If the nodule is large, high risk, there are times where we proceed directly to a biopsy just because the clinical suspicion is so high. We want to get this staged as early as possible. Or if there's any signs of lymph nodes being enlarged in the chest or anything like that that could suggest this is a malignant process, sometimes we bypass that and go directly to a procedure. But for most people, I would say for an incidental nodule, low risk, or even intermediate risk, it's usually a conversation. And then we kind of come up with a good game plan for follow-up.
Okay, great. Well, as always, thank you so much for talking to us today, Dr. Solis, filling us in about pretty much everything we need to know about asthma and reviewing lung nodules. I feel like we may need to have you back soon to review lung cancer in more detail, because that's a whole nother, it's a whole can of worms. But thank you for joining us today.
No problem. Thank you, guys.
That is it for this episode of the MedEdit podcast. If you're a clinician, do not forget to check out the show notes for your CME instructions.
And always, thanks for tuning in. Follow us on Instagram and TikTok at the MedEdit Podcast, and send us your ideas for future episodes.
Thank you for listening to the MedEdit Podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Carrie Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit Podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Carrie Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.